Assalamualaikum everyone. Now the second part of the presentation is concerned regarding the management of localized small renal masses, basically concerning about the thermal ablation and the cryoablation phenomena. Ajapul can start.
Assalamualaikum everyone, I am Dr. Ajapul, as already we have discussed. Learning objectives of our to the presentation is cryoablation, radiofrequency ablation, microwave ablation, and high intensity focus ultrasonography. Management of small renal masses, as we have already discussed in detail, surgical treatments, active surveillance. In this presentation, we will discuss briefly about the ablative approaches. We will start with the introduction. Increased incidental detection of small renal masses due to widespread imaging has now shifted the treatment protocols. Standard treatment still remains the surgical intervention, but organ sparing minimally invasive options are preferred in selected scenarios. Thermal ablation techniques that include cryoablation, radiofrequency ablation, and microwave ablation are now established as alternative nephron sparing treatment for patients with localized RCC. Other emerging ablative technology include stereotactic ablative body radiotherapy and non-thermal irreversible electroporation. A rationale for thermal ablation. Patient having medically inoperability, patient who are at high risk of surgical complications due to significant comorbidities such as poor cardiopulmonary functions, chronic kidney disease, liver disease, or bleeding disorders. Patient having small renal masses. The procedure is most suitable for small localized tumor, specifically clinical stage T1 renal masses, which are typically defined as being less than 3 centimeters in diameter. Preservation of renal functions. It is an excellent option for patient with a solitary kidney, patient having pre-existing renal impairment, or patient having bilateral tumors, as it is a nephron sparing procedure that preserves more kidney function compared to partial or radical nephrectomy. Patient having hereditary syndromes, patient with genetic predisposition for developing multiple bilateral renal tumors, such as von Hippel-Lindau syndrome and Bart-Hogg-Dube syndrome, are good candidates for repeat minimally invasive treatments. Recurrent tumors, it can be used to treat recurrent RCC after previous surgery or ablation. Patient preference. For patients who refuse surgery or wish to avoid general anesthesia, thermal ablation offers a minimally invasive alternative. Before going to forward, can someone from resident tell what are the prerequisites for thermal ablation?
If you're going for a patient for thermal ablation, any form, are there any prerequisites? These were the relative indications for the procedures. Any prerequisites which you might need to follow?
First, the biopsy of the renal mass should be done, then decided for thermal ablation.
Yes, that is right. And should the biopsy be done in the same sitting or maybe prior to that thermal ablation sitting?
Prior to thermal ablation to decide the oncological outcomes.
Yes, because the importance of biopsy lies in the fact that you need to establish firstly, is the disease, is the mass that you are localizing is benign or malignant? Because we don't offer this treatment for the benign masses. So you need to establish that this is a malignant thing before proceeding for any form of thermal ablation. Definitely, you cannot get the biopsy result on the same day. So you need to perform the biopsy prior before going for any form of thermal ablation. Okay.
So, biopsy-proven malignancy. A percutaneous biopsy is generally performed prior to the procedure to confirm the diagnosis of RCC and rule out benign tumors. Technically feasibility. The tumor location must be technically amenable to complete ablation while minimizing risks to adjacent critical structures like bowel, ureter, or major vessels. Types of the thermal ablation, we have cryoablation, radiofrequency, and microwave ablation. Cryoablation. Cryoablation for small renal masses is a minimally invasive nephron sparing procedure that uses extreme low temperature to destroy cancer cell while preserving surrounding healthy kidney tissues. It can be performed by two approaches, percutaneous or laparoscopic. Percutaneous cryoablation. This is typically performed by an interventional radiologist. It is performed by inserting fine needles cryoprobe through the skin and into the tumor under real-time imaging guidance, CT or ultrasound. This approach often uses local anesthesia with sedation and is associated with shorter recovery times. Laparoscopic cryoablation. This approach is usually performed by a surgeon under general anesthesia using a laparoscope inserted through small incision to directly visualize and assess the tumor. This allows for increased precision in probe placement, specifically for anterior or complex tumors, and help ensure that nearby organs like bowels are protected. Mechanism of action in cryoablation. Once the probe are positioned within a tumor, the process involves freezing. Pressurized organ gas is circulated through the probe, causing rapid cooling and forming a visible ice ball around the tumor. The goal is to reach lethal temperature, often below -40 centigrade, throughout the tumor and 0.5 to 1 centimeter margins of healthy tissue. Basically, freezing leads to crystal formation, intracellular and extracellular. In intracellular crystal formation, the membrane rupture and organelle rupture, and extracellular crystal lead to draw the water inside the cell from outside, leads to cell dehydration and shrinkage. Thawing. The tissue is then thawed either passively or actively using helium gas, allowing for cell damage through the physical effects of ice crystal formation and osmotic stress. A repeat cycle. This freeze thaw cycle is repeated one or more times to maximize cell death and increase the likelihood of treatment success. Mechanism of destruction is we have already discussed. Cell death result from direct injury from intracellular ice crystals, osmotic dehydration, and indirect damage through microvascular thrombosis and ischemia. Image monitoring. A significant advantage of cryoablation is that the formation of the ice ball can be monitored in real time using CT or ultrasound imaging, ensuring the entire tumor is encompassed. We have a short clip.
Just before you go to the clip of cryoablation, this technique is around us for the past maybe 30-35 years. But the improvement now is in 1990s when ice balling actually starts, nobody can stop it. So the icing actually doesn't stop on its own. It will be stopped by certain factors, for instance, the heat sink phenomena. Now the freeze-thaw cycles are in the hand of the software, which is installed within the machine. And these freeze-thaw cycles are actually in a frequency that they can agitate the cells to come closer to death. So they kind of oscillate the cell the same manner in which the energy source oscillates the cell. For instance, the ultrasonic energy or the electromagnetic energy. So the phenomena remains the same, but the energy source here is different. So ice ball now can be stopped whenever you want to stop it or wherever you want to stop it. And that makes it now more controllable as compared to 1990s.
Cryoablation is a minimally invasive procedure in which ice is used to freeze and destroy targeted tissue. Cryoablation needles work by leveraging Joule-Thomson thermodynamics to cause rapid freezing or rapid thawing. This rapid drop in temperature induces ice crystal formation into an ice ball that surrounds the targeted tissue. Within the core of the ice ball, or the kill zone, both extracellular and intracellular ice forms, which penetrates, damages, and destroys cells. Towards the edge of the ice ball, or the transition zone, extracellular freezing creates a hyperosmotic environment that pulls water out of the cell, causing the cell to severely dehydrate and damaging intracellular enzymatic function. Next, rapid thawing creates a hypotonic environment, and water rushes back into the cell beyond its capacity, which ruptures the cell membrane. This freeze-thaw cycle is repeated to ensure all cells within the targeted region have been destroyed. Vascular stasis, or damage to the cell microvasculature and support system, further decreases likelihood that tumor cells will recur. Cryoablation lethal dose factors can be customized to suit different treatment needs. Cellular destruction and death continues as an ongoing process in the hours and days post-treatment, leaving behind healthy, non-cancerous tissue.
The other thing is the temperature that you have mentioned is -40. It can drop down to -69 because the actual element which drops down the temperature is liquid nitrogen. So the liquid nitrogen works around -69 to -70. So that is the ultimate limit to which the temperature can drop.
Now we have radiofrequency ablation. Radiofrequency ablation of a renal mass is a minimally invasive image-guided procedure that uses heat to destroy cancer cell. Radiofrequency ablation works by delivering a high-frequency alternative electrical current. Current is delivered through needle-like electrode placed directly into the tumor. CT or ultrasound image is used to precise an interventional radiologist. It can be performed by dry or wet technique. Ablation cycles. Once the probe is correctly positioned, the radiofrequency energy is applied for several minutes, typically 6 to 15 minutes per cycle, often in multiple overlapping areas to ensure the entire tumor and a small margin of healthy tissues are treated. In radiofrequency ablation, the term dry technique and wet technique refer to different methods of managing heat and impedance at the interface between the electrode. Heat management in dry technique, no active cooling, heat builds rapidly. In wet technique, use internal cooling or saline infusion to manage heat. Tissue impedance. In dry technique, rapid increase in impedance due to chair tissue. This dry tissue has a very high electrical impedance, which limits the flow of further radiofrequency current and prevent the heat from effectively spreading further into the tumor. In wet technique, this system continuously circulates a cooling fluid, which keep the tissue immediately adjacent to the probe tip below the chairing threshold, which prevent the rapid rise in impedance and allow for more energy delivery further into the tissue. Ablation zone size. In dry techniques, smaller, typically less than 4 cm. In wet techniques, larger, can exceed 5 cm. Efficiency. Less efficient for larger tumors and vascular areas, but wet technique more efficient and predictable for larger lesions.
Radiofrequency ablation, these both techniques are basically used to control the amount of heat that is basically being passed on to the normal tissues. Dry technique does not use any coolant. On the other hand, wet technique is another newer form of the modality that basically uses some coolant, some liquid flowing through that basically prevents the heat spread from spreading to the adjacent tissue and preventing the collateral damage as well. So these are two modalities that can be used for both radiofrequency ablation for both of the techniques.
We have the microwave ablation. Microwave ablation utilizes
just one point, because you are talking many different technologies, and the commonality between these technologies is slightly more common. The commonality between RFA and the microwave, the other slide, is both of them are electromagnetic, but difference is in wavelength. Here the wavelength falls into radio frequency wavelength, and in microwave it falls between 900 to 1300 megahertz. So it falls in the microwave wave bandwidth. So it all depends upon the bandwidth. It's the same thing that you actually know through which your own transistor or radio works and your television works. So it's the same electromagnetics. And the basis of and the basic principle behind electromagnetics is whenever there is an impedance, there is temperature increment.
Right.
So whenever, as you have mentioned here, the tissue impedance, since the tissue is impeding its flow, then the temperature rises, and when the temperature rises, it tends to destroy any coagulative substance which is in front of it. The second thing is, there is one law that again governs all these technologies which are having electromagnetics, and that is inverse law of radiation. When you go from the center point of application to the periphery, the energy works like in concentric circles. As you go to the periphery, it drops down squarely, meaning to say by square root, not by doubling its or by reducing its energy increment. So it is decreased as you go towards the periphery. So the center point is the point where the actual tumor is, and it's the center of the tumor. But the problem with radiofrequency is if you are on the upper pole on the right side of the kidney, then it skips onto the inferior margin of the liver as well as the surrounding structures. So one has to be very careful, and the radiologists are the ones who can take care of everything where the needle is being put. So everywhere this technology cannot be used. There are certain areas of kidney and other organs where it can be used with proper dissemination without skipping into normal areas.
Microwave ablation. Microwave ablation utilizes electromagnetic wave delivered through a probe inserted directly into the tumor. The microwave energy causes the water molecules and other polar molecules within the target tissue to agitate rapidly. This constant realignment and friction generate intense localized heat, which result in irreversible cell death through coagulation necrosis. Contraindications: patient having coagulopathy, significant postoperative adhesions, intrarenal centrally located tumor, or tumor size more than 5 centimeter. Complications: the thermal ablation procedure have a low complication rate, minimal blood loss, and shorter hospital stay. Long-term studies show excellent cancer-specific survival rates over 90% that are comparable to partial nephrectomy for small tumors. Some of the rare complications may include urinary fistula, postoperative hemorrhage, injury to collecting system, injury to the adjacent structure, recurrence with the thermal ablation of tumor. Follow-up schedule. The primary tool for follow-up is a contrast-enhanced cross-sectional imaging, CT or MRI. The typical schedule is 1 month post-ablation. The first formal contrast-enhanced scan is crucial to establish a baseline appearance of the ablation zone and identify any immediate residual tumor. The treated area should be non-enhancing, which signifies successful cell death. And then 3 months, 6 months, and 12 months. Additional scans are performed at these intervals during the first year to detect any early recurrence, which typically occur at the margin of the treated area. Then every 6 months for the next 2 years, and annually after for up to 5 years. EUA recommendations offer active surveillance or thermal ablation to frail and comorbid patients with small renal masses, weak. Perform percutaneous renal masses biopsy prior to and not concomitantly with thermal ablation, rating strong. When thermal ablation or active surveillance is offered, discuss with patients about the harms, benefits with regards to oncological outcomes and complications. Strong. Do not routinely offer thermal ablation for tumor more than 3 centimeter and cryoablation for tumor more than 4 centimeter. Weak. These are the future trends, not standard care of treatment, but we have thoroughly discussed about. We'll discuss about extracorporeal high intensity focus ultrasonography. High intensity focus ultrasonography. The benefits of high intensity focus ultrasonography is being truly non-invasive, no incision, no probe insertion. Uses highly focused ultrasound wave to generate intense heat over 65 centigrade within a target area deep inside the body, causing precise coagulative necrosis, leading to cell death. The surrounding and overlying tissues are spared because the energy is only concentrated at the focal point. Limitations of high-intensity focal ultrasonography. Anatomical challenges: the kidney position behind the ribs and the presence of perirenal fat interfere with the ultrasound beam's path, causing energy attenuation and unreliable focusing. Organ movement: the kidney move with respiration, making it difficult to precisely target the tumor and ensure complete ablation. and incomplete ablation. Early studies showed post-therapeutic effect with significant amounts of viable tumor tissue remaining after the procedures. Thank you.